Ya lo silencié.
Hello, my name is Pablo Casillas Espinosa, fellow from the Department of Neuroscience at Monash University and the Department of Neurology at the Alfred Hospital in Melbourne, Australia. I'm a member of the Young Epilepsy section of the International League Against Epilepsy, or YES ILAE, and it is on behalf of YES, it is my pleasure to welcome you to a double webinar presentation featuring Dr. Emma Foster and Professor Patrick Kwan. As always, please leave your comments and questions in the box below, and we will ask them to our speakers at the end of their talks. Dr. Emma Foster is a neurologist at the Alfred Hospital here in Melbourne, Australia. She is co-head of the first seizure clinic. She's also an early career researcher, currently completing her PhD through Monash University. Her main research interests are in optimizing first seizure and epilepsy management. We also have joining us this morning Professor Patrick Kwan. He's a professor of neurology at the Department of Neuroscience at Monash University and is the director of the epilepsy program at the Alfred Hospital in Melbourne, Australia. His main research interests include treatment outcomes, personalized medicine, and drug development. Professor Kwan has also served on a number of ILAE commissions and task forces, including as chair of the Medical Therapies Commission from 2013 to 2017, of which he remains a core member. Without further ado, I'll leave you with Dr. Emma Foster, presenting the cause of epilepsy and the urgent need for better seizure control. Thanks again for joining us, Emma.
Thank you very much for having me, and thank you, Pablo, for that very kind introduction. So my talk will be on the costs of epilepsy and the urgent need for better seizure control. And this research is in the field of health economics, which is probably different to where a lot of you work. I understand a lot of the YES membership are basic scientists, work in translational research, or are clinicians. However, this research that I'll explain today may be quite useful in terms of considering the impact of the excellent work you do and how that might translate to better health economic outcomes for people with epilepsy. It might be particularly useful when applying for grants or funding to demonstrate that the work you do really will translate to important benefits for everyone. I've got my email address there, emma.foster@monash.edu. And if you are watching the talk on delay on YouTube, I'm very happy to keep in touch and answer any questions that you might have arising from this talk today. Professor Patrick Kwan and I both work in Melbourne, Australia. So we're down south, and we've just come out of a 6-month lockdown for the pandemic. And I'm aware that a lot of listeners at the moment are about to go into lockdown or have just started another lockdown. So our thoughts are with you, and I hope you all take care and are able to hopefully see your families at Christmas. This is where Professor Kwan and I work at the Alfred Hospital. The brown building there is the main hospital, and the white building in front is our intensive care unit with a helipad. And probably like a lot of hospitals where you work, we have many research institutions attached to our hospital. And you can see on the left of the brown building, the grey buildings, which are the Baker ID Institute, which looks more into heart disease, the Burnett Institute, which focuses more on immunology. And at the very end, that white and black building is where Professor Kwan and I work at Monash University at the Central Clinical School. And the research I'm presenting today will be, or has been published online in Neurology in September, with the hard edition coming out soon. So in overview, 45.9 million people around the world have active epilepsy. This carries substantial burden. It's primarily measured in terms of disability-adjusted life years. The Lancet Burden of Disease Studies has found that epilepsy accounts for 0.5% of disability-adjusted life years for all diseases and injuries, and 5% of disability-adjusted life years for all neurological diseases. Far fewer studies have looked at the health economic burden of epilepsy. Those that do exist tend to focus on the healthcare utilisation costs, such as hospitalisations. We really lack data regarding the impact that epilepsy has on people's ability to work or their productivity. Epilepsy can affect your ability to work in two main ways. Firstly, the quantity. People with epilepsy may take longer to complete training or their schooling, and so enter the workforce later. And people with epilepsy may be forced to leave the workforce early due to early retirement or premature death. The quality of work can also be affected through things such as side effects from anti-seizure medication. So our research wanted to look at what the epilepsy-related productivity burden in Australia was, how much that costs society, and how that could be improved. So the aims of the study were to capture this epilepsy-related productivity burden across different demographics in Australia to have a really specific and detailed understanding of where the burden was felt greatest. We wanted to calculate the benefits possible with improvements in seizure freedom, and we wanted to keep it realistic by improving seizure freedom a small percent and seeing how that influenced outcomes. And the outcomes we looked at were death, years of life lived, productivity, and healthcare costs. So to start with, how do you capture productivity? These productivity indices, which is a metric, a number between 0 and 1, given for each year lived in a certain health state. Number 0 is for someone who doesn't work at who works full-time in perfect health. That number is derived by a combination of factors: absenteeism, which is time off work due to illness; presenteeism, which is time at work but not working at your full capacity due to illness; and time in the labour workforce, which is a combination of people who are working or who are actively looking for work. So mixing those factors together, we calculated that in Australia in 2017, so pre-COVID, the average worker in Australia had a productivity index of 0.96 each year. People with epilepsy in Australia had a reduced productivity index of 0.75. We then took these productivity indices and multiplied them by years lived in the labour workforce to derive productivity adjusted life years, which is sort of a health economic correlate of DALY, the disability adjusted life year. We then wanted to put a monetary value on the PALY. We took the total gross domestic product of Australia in 2017, which was about $1.33 trillion, and that's the total value of goods and services produced by the country for the year. And we divided this by the number of equivalent full-time workers. which is about 5.9 million. On average, every full-time worker would contribute $221,764 to the GDP. That's not the people's take-home wage. In 2017, the median salary was $48,000. Rather, that's the value that the person's work contributes to the economy each year. So on the left, if you have someone in perfect health working full-time for 1 year, you would adjust their productivity adjusted life year would be valued at $221,764. On the right-hand side, if you have someone whose productivity is slightly reduced because of their epilepsy, they would have a reduced a contribution to the GDP of about $177,411. So over the year, for one person who has a slightly reduced productivity due to their epilepsy, there would be $44,353 less contributed to the GDP. And if you multiply that over the working lifetime of the person and expand it across to everyone who has epilepsy, that would work out to a substantial amount of money. And that's what we wanted to look at. So going from there, where we've talked through how we've captured productivity and given it a monetary value, we then created life table models. So these are tables for males and females stratified into 5-year age brackets over the working age. And we took that to be 15 to 69 years. We used published population and epilepsy-specific data regarding prevalence, mortality rates, workforce participation, and healthcare costs specific to each age sex bracket to get really detailed demographic data. The sources include the Australian Bureau of Statistics, the National Health Survey, Deloitte's, Australian Institute of Health and Welfare, and World Bank data. We then calculated the productivity adjusted life years, or PALYs, for each age and sex bracket. And then we followed up each age sex bracket until age 70 or death. So our cohort started in 2017. So if you were 60 years old in Australia with epilepsy in 2017, you'd be followed through for 10 years. If you're 25 years old with epilepsy in 2017, you'd be followed through for 45 years. And all those years lived calculated gave the working lifetime of this epilepsy cohort. So this is a schematic of our life table model. So in there you have the age and sex brackets of Australians with epilepsy. We further divided this group into those who are seizure-free and those who are not seizure-free. And that's because there's substantially different burden of disease between these two groups. And we applied the not seizure-free and seizure-free epilepsy-specific data in terms of productivity indices, healthcare costs, and mortality for each group. We then recreated this life table model. So we took the same number of people in each age and sex bracket, but we applied the general Australian population data in regards to productivity indices, healthcare costs, and mortality. We then looked at the difference between these two life table models, and the difference of simulations was the epilepsy burden, and this was measured in terms of years of life, deaths, productivity, and healthcare costs. We also ran several hypothetical scenarios where we looked at an increase in seizure freedom and how that translates to changed outcomes. So we had a baseline seizure freedom of 70% and increased to 75% and 80%. So in Australia in 2017, there were 17.5 million people aged between 15 and 69. Of those, an estimated 101,646 people had epilepsy. In terms of excess mortality, when you followed up each age sex bracket until age 70 years or death, there were 14,053 excess deaths in the epilepsy group compared to the group where epilepsy no longer was present. This was proportionately greatest in those 15 to 19 years of age. Put another way, if those with epilepsy no longer had epilepsy, 56.1% of deaths would be avoided. In terms of years of life lost, there were 78,143 less years of life in the epilepsy cohort compared to if epilepsy no longer were present. On average, this works out to 0.8 years of life lost per person with epilepsy and was proportionately greatest in the 25 to 29-year age bracket for males and 30 to 34-year age bracket for females. In terms of productivity, there were 146,202 less productivity-adjusted life years in the epilepsy cohort compared to if epilepsy no longer were present. This represents a 25.8% reduction in productivity due to epilepsy. This was proportionately greatest in males 25 to 29 years and females 15 to 19 years. Now, if you convert the productivity-adjusted life years into a monetary value, this works out to $32.4 billion lost GDP in the epilepsy cohort. In terms of healthcare costs, there'd be $4.1 billion additional healthcare costs for those with epilepsy compared to if epilepsy no longer were present. This was proportionately greatest in the 65 to 69-year age bracket for males and females. So how does that compare to other common diseases? So if you compare diabetes, hypertension, and smoking-related illness, per person, epilepsy still exerts a far greater effect in terms of years of life lost and productivity-adjusted life years lost. In terms of running the sensitivity analyses and scenarios where we increase seizure freedom, if we have a look on the right-hand column there, when seizure freedoms increase from 70% baseline up to 80%, so an increase of plus 10% seizure freedom, over the working lifetime of people with epilepsy, this would translate to $1.1 billion reduced direct healthcare costs. There'd be 1,633 deaths saved. There'd be almost 8,000 years of life gained. There'd be almost 35,000 productivity-adjusted life years saved. And that would equate to $7.8 billion retained in the GDP. So there are some limitations with this study. Firstly, epilepsy is not a static disease. And in this model, we took out 101,000 patients and we followed them through until age 70. We weren't able to account for fluctuations in seizure freedom and not seizure free. And we weren't able to add incident cases into the cohort. We're currently constructing a dynamic model to allow for this. So the key points from this research is that the younger demographics carry the greatest epilepsy-related burden in terms of productivity loss, years of life lost, and death. And the elderly carry the greatest burden in terms of healthcare expenditure. Knowing where these burdens rest will allow for more targeted healthcare interventions specific to those demographics. Next, the lost productivity per person for epilepsy far outweighs that for people with diabetes, smoking-related illness, and hypertension. This really demonstrates that epilepsy carries a significant burden of disease in our society. And finally, and more optimistically, a modest improvement in seizure freedom translates to substantial health and economic benefits. So expenditure in epilepsy that leads to improved seizure control could have substantial economic benefits above and beyond the benefits to patients and their families. It also shows that low and middle income countries may have substantial gains with limited expenditure. Just wider access to healthcare professionals and effective medications may translate to even greater improvements in seizure freedom than what we discussed here. Thank you very much for your attention, and I'd like to thank my collaborators with this for this research project.
Oh, thanks a lot, Emma. It was a fantastic presentation.
Thanks, Pablo. I'll just go back there. Yeah.
Thank you. So I know that this is sort of a fairly new field and very interesting that hasn't been explored. But do you have any data from other countries? Would you expect to see something similar in other countries besides Australia?
That's a really good question. And I think this model would actually have to be applied to different countries rather than assumptions being made. Broadly speaking, Australia is a high-income country, so we would perhaps expect similar findings in other high-income countries. But in countries where there's perhaps greater treatment gaps, for example, the model could look quite different. I think the prevalence of epilepsy is a big factor as well. and which demographics are most impacted. And so different countries might have different prevalences at different demographics, and that would also change the model and the health outcomes.
Okay, I'm just going to see if there's any further questions. So just going back to the same question, Emma. So your model is fairly flexible, that you think it can be adapted to other countries, and I'm just trying to think how can be implemented, because it seems that the impact of improving the way we treat our patients, even from the first time that they arrive to the seizure clinic, is extremely important, and it's something that has been overlooked. Like how easy is to adapt your model? I'm just trying to think, as you mentioned, in countries where there are developing countries where, and I think the other question that goes next to goes in hand with this is whether whether it can be useful in countries or in areas where there's no epileptologist. So I'm not sure how your model can be adapted and how can be improved in these particular cases.
I think broadly speaking, this model is probably most constructive in terms of demonstrating the gap in seizure freedom, and every country has different abilities to close that gap. Certainly in Australia, we're very fortunate. We've got a universal healthcare system where people can access healthcare for free. And it's, however, we still find that even in Australia, there's a treatment gap. Despite well-subsidised medication and access to healthcare professionals, there are still a lot of people out there with epilepsy that's sort of suboptimally controlled. And so I think from an Australian perspective, and perhaps this would apply to other high-income countries, finding ways to improve pathways to get people into epilepsy centres to get the best possible care. And for example, for being worked up for resective epilepsy surgery would be one way in which we can close the gap. And although every country has their own challenges in terms of how we get people into pathways to get access to care, demonstrating the benefits of overcoming those barriers in terms of health economic benefits, this model I think would still be relevant and important.
That's fantastic, Emma. Thank you very much for your presentation. So now we're going to move to Professor Patrick Kwan's talk. And so we're just going to do a bit of changeover here in the channel. And I just wanted to present again for those that are just joining in now, that Professor Patrick Kwan is a professor of neurology at the Department of Neuroscience, Monash University, and the director of Epilepsy program at the Alfred Hospital in Melbourne, Australia. And his main research interests include treatment outcomes, personalized medicine, and drug development. He has served on a number of ILAE commissions and task forces, including as a chair of the Medical Therapies Commission from 2013 to 2017, of which he remains a core member. And just before we go into your presentation, Patrick, I'll remind everyone that we have several videos available in our channel. If you want to watch them or rewatch them, I think it's a very nice source of knowledge that everyone can have access to. And so at the same time, I would like to thank Dr. Jamil Calle Lopez for her help with the streaming.
Okay, well, good morning or good afternoon, good evening, all the audience, wherever you're from in the world. Welcome to this seminar. I'm very delighted to be able to be involved. So following that, I hope you find interesting take from Dr. Foster's presentation, looking at the burden of epilepsy. What I like to do is to switch gear a little bit, but not completely, because what I'm going to talk about are adverse effects or tolerability of anti-seizure medication treatment for epilepsy. And in a way, this is very much two sides of the same coin. And you've heard how improving seizure freedom could have a major impact on economically and also on a personal scale. Often we don't really pay enough or similar attention to how to improve drug tolerability or reducing side effects of treatment. And often side effects then become like the Robin in the Batman and Robin, being always the second place. But what I'm hoping to do by the end of this talk is to convince you that we really should elevate the state of for drug treatment is really a large topic, and so what I would do next 30 to 40 minutes or so is to focus on three main areas. First of all, what are the common types of adverse effects of anti-seizure medications? Secondly, with the arrival of second or even third generation anti-seizure medications, has their overall tolerability changed over time? And thirdly, what are the current strategies available to us to reduce adverse effects? And what is I'll now share some of the research that we've been conducting in our group to help achieve this goal. So just like any other drugs or classes of medications, adverse effects to anti-seizure medications can be classified into 5 different types from, often they're named from A to E. So drug A are those adverse effects that are largely dose-related, and they are due to the inherent pharmacological actions of the drug. So in the case of anti-seizure medications, these would mostly be CNS side effects, such as dizziness, vertigo, concentration, cognitive side effects, largely. Type B reactions are those that are known as idiosyncratic, which are largely unpredictable, and because they are due to individual vulnerability. Type C reactions are those that represent chronic usage of the drug, so the accumulative effects or toxicity that build up over time. Type D reactions are those that are most relevant to, obviously, women of childbearing age, often in terms of teratogenicity, but also would cover carcinogenic effects of some medications. And there's another type known as type E, which are not directly related to the drug per se, but more due to adverse drug-drug interactions. Side effects, as I said, are really important in epilepsy management. And this is a classic study by Frank Gilliam showing that there is a direct tight correlation between the burden of side effects and the patient's quality of life. As you can see here, those patients with a higher adverse effect profile score, which is a quantitative measure of adverse effect burden, the higher the score, the lower the quality of life as measured by quality 89. And this is really a very tight correlation, and the effect of side effects on quality of life is often greater than just reducing seizure frequency per se. We've also shown in our initial analysis of patients with newly diagnosed epilepsy in the Glasgow cohort that among the patients treated with the first ever anti-seizure medication, a proportion of them did not have their epilepsy controlled. And the reason for failure in 40% was due to side effects, either the type A, the dose-related side effects, or idiosyncratic reactions. And so poor tolerability is a major cause for treatment failure in our patients. Now, these are studies, this is initial analysis was published some time ago now, and in the interim year, a number of new drugs that have been developed in the market, and often these are now called second or third generation anti-seizure medications. So a natural question would be, do these drugs have better side effect profiles, and are they better tolerated than the older medications? So to answer this question, we've been reporting a series of analysis coming from this Glasgow data registry, and these number of studies adopt a similar methodology in that the cohort is an expanding cohort of patients who are newly diagnosed and newly treated for their epilepsy. They include patients from adolescents to elderly, and the clinic that was set up back in the early 1980s. So this provides an opportunity to follow patients up longitudinally and therefore allow us the setting to look at how the increasing use of new drugs have impacted patient outcomes in the real-world setting. And in the latest analysis we published a couple of years ago in JAMA Neurology, this now the cohort has expanded to nearly 1,800 patients. As you can see here, there were slightly more male than female patients, with the median age of onset at 30, and although with a very broad minimum to maximum age of onset. As you expect in a largely adult population, most of the patients had focal epilepsy syndromes rather than generalized. And in this slide shows the shift in the usage of anti-seizure medications over time in this cohort. As you can see here, plotting against the years over this 30-year period, you can see that there was a decreasing use of the older drugs over time, as demarcated by this dotted yellow line here. So each color you can see on this graph represents one anti-seizure medication, either established or the newer ones, which are the second or third generation ones. So there's been a progressive decline in the use of the established drugs and an increasing use of the newer drugs over time. So clearly these new drugs are being increasingly adopted. And this sort of pattern can probably be seen in other similar setting and probably in your own clinic as well. So the first question we ask is that, do these new drugs or different drugs have different tolerability in terms of whether they need to be withdrawn as a first drug due to adverse effects. So this grid shows the comparison between drugs on the columns and on the rows here, and the numbers within each square represents the adjusted hazard ratio of withdrawal of the drugs on the rows compared to a drug on the columns due to adverse effect. And those square with a solid outline are those that the difference was statistically significant. So for instance, you can see here that oxcarbazepine was 1.9 times hazard ratio higher than levetiracetam to be withdrawn due to adverse effect when it was used as the first monotherapy. And so you can see here that some drugs there you could find a significant difference in terms of tolerability when used as a first monotherapy. We also examined any change in side effects profile over time in this patient population. To do this, we divided the population or the time period into three roughly 10 year epochs, as you can see here. And over time, there seem to be some significant changes in the types of adverse effects that led to medication withdrawal in this setting. And most obviously is the increasing proportion of patients who had to withdraw medications due to psychiatric disorders over time. And this probably would be largely attributed probably to the increasing use of drugs such as levetiracetam, which has more psychiatric adverse effects than some of the older medications. So we see here that there are some individual drug differences, but over time the profile of adverse effects has also changed over time. So that's a little change in the overall tolerability over time in these three epochs. So this is a survival curve analysis, as you can see here, of patients who commenced treatment in these three time periods. As you can see here, looking at the probability of withdrawal due to adverse effects, there was no significant difference in patients who started treatment in these three time periods when they were receiving more and more new medications over time. No overall ability to do within patients. How to use drugs in a better way to avoid side effects. And to do that, we can look at what are the risk factors for side effects. Some of these are very general risk factors. So we know that the more medications the patient takes, the more likely the regimen would cause adverse effects. We've learned to avoid increasing dosage too quickly, start with low doses, and these are common practices in epilepsy management to avoid adverse effects. We know that patients who have comorbid mood and anxiety disorders are more likely to experience adverse effects, and female patients have also been shown consistently to have a higher risk of developing adverse effects to anti-seizure medications. And this is not just to anti-seizure drugs, it's across different drug classes, and also patients at the extreme of ages. So these are general risk factors, and some are modifiable and some are probably not modifiable. But by paying attention to these, one may have a strategy to avoid adverse effects. What about specific types of adverse effects? For type A, which really is largely dose related, we've learned, as I said before, to start with a low dose and go slow. And there's been a number of studies demonstrating that the use of control release rather than immediate release formulation drugs can improve drug tolerability. And it's particularly, I think the best evidence is for carbamazepine, whereas for other control release formulations, there's relatively less evidence due to lack of head-to-head comparisons. It's been also shown that by just actively asking the patients in using standardized scales such as the Liverpool Adverse Effect Profile or LAEP, by just doing that, that's enough. That can lead to a significant reduction in adverse effects of patients over time. And in places where there are epilepsy care nurses, then they can also play a very important role in patient education in how to avoid these type of adverse effects. What about type B that are traditionally known as idiosyncratic? And this is, I think, an area where there has been quite important breakthrough in the last 10 to so years in identifying pharmacogenetic biomarkers of either drug-specific or ethnicity-specific biomarkers that can lead to these adverse effects. The best example is, of course, the HLA genotypes, which predisposes patients to develop severe skin reactions to carbamazepine or other aromatic anti-seizure medications as well. The best known example is the HLA-B1502, which is strongly associated with carbamazepine-induced Stevens-Johnson syndrome or toxic epidermal necrolysis. And screening is now recommended by the FDA in Asian populations, including Chinese or Southeast Asians. There is some evidence of HLA-A3101 as well in Asians, but the stronger evidence comes from Caucasian populations, such that Caucasians who carry the HLA-A3101 should also avoid taking carbamazepine. There's been some data coming from collaborative effort in showing that the HLA-A2402 may also be relevant in southern Chinese populations. There are many other HLA different alleles have been reported to be associated. A lot of them have not been replicated in studies. And so this is a very fast-moving field. The problem with all these markers at the moment is that the testing itself has a long turnaround time and is expensive, which affects how it's implemented. The other main problem is that even for the marker with the highest odds ratio, which is the HLA-B1502, it still has a very low percent in general, suggesting that there may be modifying variants which have not been identified. The problem with the first problem is can be highlighted here because the current to do a genetic test, it faces many logistic and economic barriers. And if you can imagine, the last time you try to operate, the patient will have to go to the pathology lab, have their blood taken, have the sample sent to the lab, and then by the time the results come back to the doctor, you arrange another appointment with the patient. This process takes days or even weeks in some scenarios. And this causes, I think, a major problem in disrupting the clinical flow in that either the patient leave without a script at the first appointment, or you have to give them something else and you have to bring the patient back for another appointment. And this is very clunky, very also not a very cost-effective way. What we really need is a point-of-care test where the test can be carried out at the clinic, similar to a blood glucose test, so that the result can be available immediately and the appropriate prescription can be given to the patient within that first appointment. And this is something that we've been working with engineers to try to develop a point-of-care diagnostic test to detect HLA-B1502. And in this proof of concept study, we show that using what is called as an interdigitated electrobio sensors, essentially these are tiny sensors that are arranged like digits that cross each other. That's why they're called interdigitated. By functionalizing them using a probe, you can then detect amplified region of the HLA-B1502. And when this amplified product, using a very rapid amplification method that binds to the probe, it changes the electrical property of the sensor, and which can be detected using an amplifier. And we've shown that just using crude blood samples without DNA extraction, we can achieve sample to answer in about an hour and 20 minutes with a reasonable sensitivity and specificity, which we're hoping that can be improved further. And because this system can be miniaturized, then it can be further developed into a complete system where you collect a small drop of blood and then put it on a sensor, which can be operated using a phone to deliver the results within a short period of time. And this sort of system, obviously by using a probe, is very specific. You look at a specific genetic variant in mind. So it's useful when you know what you're looking for. However, if you want to screen the whole exome or genome, then you need to look for other solutions. And one such solution include the Alfred nanopore technologies, which has reported to be able to assemble the genome within a small device like this. And with this sort of device, the requirement is still obviously very high quality DNA, so you can't really start with a raw blood sample, but it does give the possibility of doing genome-wide screening at the point of care. What are identifying potentially modifying variants? And this is a study we've recently completed, looking at over 100 Chinese recruited from southern China and Malaysia of patients who developed anti-seizure medication-induced carbamazepine. Most of them, and as well as other anti-seizure medications, and matched them with drug-tolerant controls. And we performed a whole genome sequencing study. And from the whole genome, we extracted the common variants, and over 6 million that's higher than you would find in a normal SNP chip. And with this, we were able to identify 5 variants which reached genome-wide significant, as you can see here. And these these variants were all non-protein coding, and they modulate the risk of the individuals based on their HLA-B1502 carrier status. And this may explain why some patients who are HLA-B1502 negative will nonetheless develop carbamazepine SJS, and conversely, why people who are carriers of the HLA-B1502 are able to tolerate carbamazepine. With gene expression analysis, we also found that these SNPs may affect gene expression in the skin, and which may be a biologically plausible explanation of their functions. What about other types of idiosyncratic reaction? One of these is psychiatric or psychotic symptoms. And this is a study performed between Dr. Chen from China as a epileptologist and Anna Lucicic, who's a neuropsychiatry fellow at our center, when we reported this a few years ago. The idea was to develop a unified way to diagnose anti-seizure medication-induced psychotic disorders. And to do this, we brought together 2 classification schemes, one from the ILAE in diagnosing psychosis, epilepsy, and one from DSM-5 in diagnosing substance-induced psychotic disorders. And we're able to come up with a unified approach to diagnosing AED-induced psychosis. And we then apply this definition in our patients who have been admitted for video EEG monitoring over a 20-year period. And we identified 2,630 patients. Of these, 98, that's 3.7%, admitted over this period, had experienced psychosis. This is the median age of onset of the epilepsy and psychosis, and indeed 6 developed psychosis during the VM admission. And the table here shows the type of epilepsy these patients had, and also because all patients who are admitted for video EEG monitoring in our unit routinely receive a formal neuropsychiatric assessment, and this allows us to classify the types of psychotic disorders into several different types here. And I want to draw attention, you can see here that of these patients who developed, these 98 patients who have psychosis, 14 of them, that's 1 in 7, were due to anti-seizure medications induction. And these were the culprit drugs. As you would expect, there is a significant risk associated with levetiracetam. And once we put all this into a multivariable model, emails and temporal involvement and current use of levetiracetam were significant risk factors for developing AED-induced psychosis, whereas the concurrent use of carbamazepine was associated, interestingly, with a low risk. And so this would identify these risk factors, may allow one to be more vigilant and may even influence how you choose anti-seizure medications for your patients. And these findings have been, I think, confirmed in a subsequent study from a Canadian group where they developed a scoring model of patients developing psychiatric adverse effects when given levetiracetam. And the model included a number of risk factors, including women, female sex, any pre-exposure history of higher social deprivation, depression, anxiety, or recreational drug use. And by including these factors, one can use the model to develop a prediction of the chance or how likely a patient may develop psychiatric adverse effects if given levetiracetam. So just moving on, what about type C? And these are chronic toxicities. And in a way, showing the chronic toxicities to the older drugs, these are very drug specific and largely they're related to the either the pharmacodynamic. It's probably not a lot you could do other than being aware of these potentially happen, and this shows that the newer drugs are not good of these chronic toxicities. And one needs to be aware of these potential chronic toxicities and monitor them in patients who are taking these medications in the long term. So while there's probably not a lot we could do at the moment for type C reactions, for type D reactions, there have been major advances in the last couple of decades. And these are largely due to a lot of effort in a number of national and international pregnancy registers of women who take different types of anti-seizure medications during pregnancy and looking at the birth outcomes. And this is a data taken from Europe, the largest international epilepsy register of women taking anti-seizure medications during pregnancy. And in a paper we recently published earlier this year. So this slide shows the, I think, two main messages. First of all, the prevalence of major congenital malformation differs between drugs, is drug dependent. As you can see, drugs such as the older drugs, which are red here, generally have a higher prevalence of major congenital malformation in children exposed to the drug in utero, compared to the green dots here, which are the newer ones. And the second important message here is that the prevalence is dose-dependent as well. So as you can see in these examples of phenobarbital, valproic acid, and carbamazepine, and also for lamotrigine, you can see a clear dose relationship such that at high dose valproate, the prevalence of congenital malformation in this study was as high as 25%. And this is really a staggering figure. And that's formed the basis, of course, as you know, to the current warning of prescribing valproate of change. So whereas compared with the newer drugs, and that's, I think, a clear advantage of at least these newer drugs, that we have sufficient evidence that they are much safer than the older ones for women to take during pregnancy. And this knowledge, I think, has really translated into practice, as we can see on this slide. So these colors here, similar to the one I showed you earlier on, showed the prevalence of using these different drugs over time, that the register has been in place. As you can see, over time, there has been a less and less use of the older drugs, in particular carbamazepine and valproic acid, whereas there has been a corresponding increase in use of newer drugs, such as lamotrigine here and levetiracetam. And plotted on this is the prevalence of congenital malformation recorded in Europe over these 20 years. So as you can see, with the increasing use of the newer ones and decreasing use of the older generation of drugs, we've seen a gradual decline and significant decline in the prevalence of major congenital malformation from nearly 7% when the register started to less than 4%. And this is largely, I think, can be attributed to this change in choice of drugs, also dosage as well. What remains unclear is why some women when they take anti-seizure medications, will deliver children with birth defects, and some don't. And genetics obviously is a potential explanation. So in this study just published by Piero Perucca and Alison Anderson, led by the two of them in our group, we performed a hypothesis whether AEDs can induce de novo mutations, which can then destabilize the embryonic genome and act as a common mechanisms for these reactions. And this was a truly international study with child-parent trios recruited from Australia, Europe, and North America. In this study, we included 56 children exposed to anti-seizure medications in utero, with 10 of them developing birth defects, and compared to 11 children who were not exposed to anti-seizure medications in utero. And we performed whole exome sequencing in these child-parent trios. And this slide shows the 10 drug-exposed and affected children with the various types of birth defects and the drugs they took, or the mothers took, I should say, during pregnancy. As you can see, there are many, as you expect, valproic acid and carbamazepine, some only of the newer drugs. And then this slide shows the comparison of the number of de novo mutations or variants, comparing both the children who were exposed to AED and the unexposed, and there was no difference between these two groups. Of the patients, of the AED exposed children, there was also no difference in the number of de novo variants between those who were affected and those who were not affected. So what it means is that despite the relatively small sample size, we were confident that the prenatal ASM exposure does not increase the burden of de novo variants, and this mechanism is unlikely to be a major contributor to drug-induced birth defects. So at the moment, what can we do? I think there's still a lot we can do to reduce teratogenicity. And the most important is careful planning. And with planning, then you can look at whether it's possible to withdraw anti-seizure medication treatment altogether, and if not, can you use monotherapy and use the lowest possible dose and choose the safest medications, and providing folic supplement, although the benefit of this is still under debate in this setting. But nonetheless, by careful planning, it is possible to minimize any teratogenic risk. And last but not least is what are called type E reactions, and these are due to drug-drug interactions. And it's very relevant in anti-seizure medications, of course, because the older ones are notorious enzyme inducers, inducing the cytochrome P450 enzyme system, which is the major drug metabolizing system in our body. And this, again, is another clear advantage of many of the newer medications in that they are much less likely to have such interaction because they do not affect this drug metabolizing system, although some of the newer drugs can also have a limited effect. And the enzyme induction, apart from causing drug-drug interactions, can also have other broader deleterious health issues, such as bone health, and also increasing vascular risks through its effect on cholesterol and as demonstrated in some inflammatory markers. And in this study, we performed in a cohort of patients in Hong Kong using data linkage of over 7,000 patients with newly diagnosed epilepsy. We found that patients who were treated with enzyme-inducing anti-seizure medications were more likely to develop new comorbidities compared to those who took only non-enzyme-inducing drugs, and resulting in a higher Charlson comorbidity index. And this index is associated with survival over time. And in particular, those patients who took enzyme-inducing drugs were more likely to develop cerebrovascular disease and liver disease. And so this effect is quite likely to be due to this type E adverse effect. So to conclude, I hope I've shown you that adverse effects are a critical determinant of epilepsy treatment success, and the newer drugs overall have not improved the tolerability of epilepsy drug treatment. However, by personalizing drug characteristics, we can reduce or avoid these adverse effects. This can be further done in terms of identifying more precise determinant of these risk factors, in particular using pharmacogenetics. And we've seen the clear example of pharmacogenetics impact on preventing carbamazepine-induced SGS. So the current testing method, as I've shown you, faces a number of barriers, which can hopefully be addressed by novel medical technologies. The genetic basis for ASM-induced heterogeneity remains to be discovered. But overall, I hope I've convinced you that we need to elevate the status of Paul Robin to emphasize more research in drug development in improving anti-seizure medication tolerability. Thank you very much for listening.
Okay, Patrick, thank you very much for this amazing presentation. If you don't mind just keeping your presentation still on display, we have a few questions from the audience. One of them is, how frequent are the cosmetic side effects of levetiracetam seen in clinical practice, such as hair loss? And which options for management do we have for those besides stopping medication?
Personally, I haven't come across a lot of cosmetic side effects with levetiracetam, which of course is more frequently associated with more behavioral side effects. And how do you manage, I think, is a really good question. And in particular, some of the less, such these kind of less common side effects. And first is, how do you determine whether there is a causal relationship or is purely coincidental? And I think that's you really have to obviously go to take a very careful history from the patient and balance. It's a careful balance against what are the risk benefit of reducing or stopping the medication versus risking emergence of risk versus worsening seizure control. I think for some of the more obvious or well-known side effects, particularly like skin rashes, then the immediate management and safest option would be to cease the medication. However, in some scenarios where the patient is benefiting from the drug treatment efficacy, And when the skin rashes are not too severe, you could try reducing the dosage or using anti-allergic treatment to try to manage the situation. And in some scenarios, I've seen success. And it's all very much a balance act of having the patient benefiting from seizure control versus tolerating any side effects.
Okay, thank you. And so, have the different side effects of the ASMs been explored in different populations? Because it's presumable they will be different because of all the genetic differences between populations. Yeah. I'm not sure if this has been explored before.
Yeah, that's an excellent question. So most of the studies I've shown you have been, I think, a lot of gain performed in looking at skin adverse effects, the particularly more severe skin reactions, the SGS or 10, or some of the milder rashes. There's also been studied, and those studies have clearly demonstrated the risk can be ethnicity dependent, but can also be shared between different ethnicities. There's much less in terms of pharmacogenetic research that's been done for other adverse effects.
Okay, thank you. And so another. Patrick, yeah, we have a. There you are. So we have another. We have a question from Emma. So so you have shown that the ASM carry a significant side effect burden. So what do you see on the horizon in the next 20 years for epilepsy treatment that may complete or that might complement or replace the current ASMs?
Not entirely sure the question, but in terms of looking at non-drug therapies, obviously there are other non-drug options. But I think within drug treatment, we really should start thinking of right at the development stage a more systematic or more rigorous analysis of adverse effects. Because if you imagine the standard way of comparing a head-to-head trial is looking at the proportions of patients who would stay seizure-free on that medication. And so anyone who a patient, if they have to withdraw from the medication, then they become they are counted as a drug failure. And the efficacy and safety are really two sides of the same coin. So a drug that is very highly effective but can't be tolerated is not a good drug. It's not an effective drug. And I think we haven't have been so rigorous in assessing adverse effects compared to assessing efficacy. So first, I think we have to start from how we develop drugs, right from the preclinical stage. And so that we're not just so one-sided looking at efficacy. And secondly, I think we should look at other ways of drug delivery. And there's been a lot of research looking at direct drug delivery to the CNS, such as into the intracerebral ventricular deliverable systems to avoid many of the systemic toxicity.
Thanks, Patrick. So on the other question that appears on the chat is that on the graph that you showed, it seems that the type D reaction is less prevalent in the second generation ACMs. Do you have any idea what this might be the case, or could it be because the second generation have in general a more targeted mechanism of action? It's
a very good question, and I would qualify, first of all, to say that this observation so far has only been limited to a few second-generation drugs, and that's because we just simply don't have enough data for many of the newer drugs to generalize, to say that the newer drugs are necessarily safer for pregnancy than the older drugs. So I think we still need to be cautious in stating that. But nonetheless, some of the, at least I think we have enough for drugs such as lamotrigine and levetiracetam in particular to say that they are safer for pregnancy than the older drugs. I'm not aware of any robust evidence to explain the difference, but one would assume that it would be due to the pharmacodynamic effects of the drugs. Some of the older drugs have a very broader pharmacological effect. Valproate has can affect epigenetic factors as well. Maybe we haven't even touched on epigenetics, which is another large area of research. So I think the mechanisms remain to be discovered.
And so one last question, just touching on the same topic of the more recent ASMs, is do we have any evidence regarding the potential for teratogenicity from lancozamide?
I have not seen any robust evidence yet, as I said, and similarly for some of the other drugs such as propranolol, data still being collected, and sure we'll see emerging data from the large registers such as Europe.
Okay. Well, thanks a lot, Patrick, for your presentation and for answering the questions from the audience. And I just would like to thank you and thank Emma for a great presentation. So it was amazing to hear the two presentations side by side of very important topics in epilepsy. And just to remind everyone that if you can watch this video later on the YES YouTube channel. And I want to thank again everyone for joining in this morning. Thank you.
Thank you for hosting.
It's been a pleasure. Yeah.